I appreciate the opportunity to talk about actually a class of channels which hasn't been mentioned yet. In fact, I don't think anybody's even mentioned inward rectifiers in general. So this is a big class overall of potassium channels. And the KATP channels are a unique subset. They're unique because the channels, although the channels are regular, essentially regular KIR subunits, which contain the inner core of potassium channels without a voltage sensor, each one is associated with a sulfonylurea receptor protein, which is a member of the ABC C subfamily of membrane proteins, which includes the P glycoproteins and CFTR. And these act as regulatory subunits to the channel. So the channel is octameric. I can't make this thing work. Maybe I'll do it from here. No, that's fine. I'm just kidding. So the channel is octameric. And so there's 4 KR subunits, each associated with a sulfonylurea receptor. And the key regulatory elements which you need to keep in mind for what I'm going to tell you is that ATP inhibits the channel by binding to a site located on the KR6 subunit. So there's 4 of them on each channel, and which closes the gate that's classically located at the inner helix bundle. And the sulfonylurea receptors have 2 nucleotide binding folds which generate 2 ATP binding sites in each subunit, one of which appears to be degenerate and simply binds magnesium ATP. The second one hydrolyzes ATP to ADP, and it would experimentally, it's the presence of magnesium ADP, which is the activated state of the channel. So what we think happens, and there's still incompletely worked out, is that magnesium ATP binds here, it's hydrolyzed, generates ADP, and that ADP-bound post-hydrolytic conformation of the sulfonylurea receptor subunit is transduced to the channel to cause channel opening, overcoming the inhibition. So the physiologic regulation of the channels is by the ADP to ATP ratio. It translates into the channels tend to open when metabolism drops. From the pharmacologic perspective, which is what we're interested in this meeting, these channels are unique in that they have, because of the sulfonylurea receptor, they have a unique set of pharmacology associated with them, which includes sulfonylureas, which bind to a site. I took out the slide showing exactly where it is, but it binds at a location in the sulfonylurea receptor, and then close to that site, but not exactly overlapping, is a site for multiple potassium channel opening drugs, which I'll talk about the openers and the blockers during this talk. There are 2 canonical pairs of genes that encode these proteins. So on chromosome 11 in humans, SUR1, which is encoded by gene ABCC8, is immediately upstream of KCNJ11 gene, which encodes KR6.2. And through gene duplication, there's a second set of channel proteins, we don't know which one came first, which for historically bizarre naming reasons, this is ABCC9 and KCNJ8, which encode SUR2 and KR6.1. And KR6.2 is well recognized to have 2 major splice variants, A and B, where splice variant A is expressed in cardiac and skeletal muscle predominantly, and B is expressed in smooth muscle. Overall, the expression patterns for these proteins matches the gene pairing in that SUR1 and KR6.2 are highly expressed in pancreatic beta cells and alpha cells, as well as neurons. And because of this, gain of function in these channels causes neonatal diabetes. Gain of function in either of these subunits will cause neonatal diabetes by inhibiting electrical activity and insulin secretion in the pancreas. Conversely, loss of function mutations cause congenital hyperinsulinism and blood glucose lowering. So I'm not going to spend a lot of time, I'm not going to talk about those diseases now. I'm going to focus on the disease that comes from gain of function mutations in the SUR2 and KAT6.1 subunits. There's a poster outside from Colin Nicols, who's most of the work I'm going to talk about is actually his. He's sitting up there, but he's got a poster outside that's talking about what happens when you have loss of function mutations. I'm going to focus on gain of function mutations in Cantu syndrome because we now know a lot about what's going on, and there is an increasing number of patients who could benefit from some therapy. So the story from our end starts 10 years ago now, in 2012, when 2 papers came out showing that gain of function mutations in ABCC9 cause this disease called Cantu syndrome. And and there have been now multiple papers from us and other people analyzing the consequence of these mutations. The mutations in this is a molecular structure of the SUR2 subunit, one subunit, and these are the 2 nucleotide binding folds generating the ATP binding sites, and the mutations are dotted throughout the channel. But the essence of what happens is if you look over here this is showing currents in response to voltage ramps from minus 100 to plus 100 in high potassium in control conditions, and then after adding magnesium ATP, which is going to inhibit the channels, to generate ATP inhibitory dose response curves. This is not our data. And basically it's shifting the dose response to ATP to the right. So at any given metabolic state, there's going to be more channel activity. And this is commonly what we see. Oops, sorry. And then 2 years later, we and another group identified new patients who have mutations in KCNJ8 that also cause gain of function, as we showed in this paper. And that confirmed that actually the Cantu syndrome it's caused by ABCC9 is the major, that's where most of the mutations that we've identified now, we know hundreds of patients, well over 100 patients with mutations in ABCC9. There's still only maybe a dozen that we know with mutations in KCNJ8, but the fact that they have essentially the same disease, which I'm going to tell you about, means that it is the KATP channel complex that is responsible for causing the disease. It's not some alternate function of ABCC9. I said that these proteins are expressed in smooth muscle, but they're expressed in potentially other cells as well. And there is, as a consequence of where they're expressed, Cantu syndrome has many, many features to it. And this is not a complete list of what we know to date. So there are a lot of problems associated with pregnancy. The fetus causes polyhydramnios, which is increased water in the mother. The babies are born large, with large heads. They tend to be premature. There's evidence of craniofacial and skeletal abnormalities, although these tend to be minimal. I'll just touch on this later, that there's gastrointestinal problems. There can be immunologic problems, which we can't explain yet. There are not many real neurological problems. I've now met a lot of people with Cantu syndrome. They have headaches and migraines, but they don't have any obvious neurologic defect. There's respiratory tract problems. They have tracheomalacia, which is inappropriately floppy, in this case, trachea. And the biggest problems that they have internally are cardiovascular, which I'm going to come back to. They have massively enlarged hearts. They have elevated cardiac output. They have decreased systemic vascular resistance. They often get pulmonary hypertension, which we can't explain yet. They often are born with persistent patent ductus arteriosus, which requires surgical correction. They have valve abnormalities in the heart, and they have a lot of edema, which has been characterized as lymphedema in the periphery. But hypertrichosis is the one thing that you can see from outside. So over the last 8 years, we've developed a clinic to bring patients to WashU for an annual research clinic, and so we've been studying people longitudinally. We've now had over 50 patients, visitors over the years, and you can see when you look at a lot of them, you can see the commonality of their features. Sometimes this condition has been referred to as hypertrichosis acromegaloid facial appearance, and you can see that there is a commonality, that they have large lips. often. Their tongue is often swollen. They have prominent chins. They tend to have very flat noses with very broad nares at the bottom. And you can see it's evident here with this little boy. And actually, it's well hidden here, but this hypertrichosis where it's hair growing down onto the face. And you can see that more clearly in some other photographs here. This little boy has hair all over his forehead, so is this little girl. And then this is a young child with hair, a lot of hair on his back. When we look inside, one of the things we've been able to do is imaging of blood vessels in the brain. This shows a normal, this is what the normal vessels into the head look like in a young man. This is the circle of Willis, which is a classical structure within the brain. This is what it looks like in a Cantu patient. So these people have incredibly dilated and tortuous blood vessels. And if we measure cerebral blood flow, it's about double in the Cantu patients what it is in normal patients. So they have a very enlarged circulatory system, and that's why, in consequence, the hearts, if you just focus on, this is a snapshot data of what the cardiac phenotype is in a lot of Cantu patients. And the point I want to draw your attention to is, this is really all you need to look at. The left ventricular mass is around 25 grams per square meter in normal people. It's 50 in Cantu patients. Their hearts are double normal size. These people, Gautam Singh is a cardiologist, and Kathy Grange is a clinical geneticist, and she's been the one who's been directing our research clinic, and together we've been keeping it going now for 8 years. And longitudinal data, which I don't have the slide to show you, shows us that the hearts are gradually getting bigger and bigger over time. And in all patients over 50, which all happen to be female in our case, they are in increasing stages of heart failure. So although this isn't any classical congestive heart failure or anything like that, it is a condition which is somewhat similar to athlete's heart, but it's one that is leading to a gradual loss of reserve, presumably, in what the heart is capable of responding to. Mark Levin was a pediatric cardiologist who was involved in these studies as well. So to get further insight into what's going on, and to begin to look at how to develop some sort of therapy for this, we started generating CRISPR-Cas9 knock-ins of Cantu syndrome mutants, and this is the work I'm going to show you now is predominantly the work of Yan Huang, who was a student from China. She's gone back to China now, together with Connor, that's cheeky chirpy Connor down there, and my long-term collaborator, Maria Remedy, who generated the animals in the first place. And we made two animals, one of which had a A478V mutation in SUR2. It's one of the more severe mutants in terms of what it does to the gain of function. And V65M in KR6.1. It's an even more severe gain of function effect. And I'll show you the differences, and I'll highlight the differences as we go on between these two models. So first thing we looked at, is to look at the vasculature. This is showing images of the aortic arch from echocardiography from wild type, and in this case, one of the V65M het mice. You can see that the arch is much bigger. It's dilated. And what we predicted all along is for a gain of function of KATP in the vasculature is that there would be lowering of blood pressure. But that had never actually been reported for Cantu patients. And by the way, Cantu syndrome was named after a Dr. Cantu from Mexico who first described the collection of features about 30 years ago. But what we see if we measure blood pressure with, this is an anesthetized mice with a cannulated jugular. The wild type the wild type blood pressure is between about 80 and 100 millimeters of mercury. For the VMs, it's about 30 millimeters of mercury lower. So this is a massive lowering of blood pressure in the face of other potential compensatory mechanisms, which presumably are still there. What happens here is adding pinacidil, which is one of these potassium channel opening drugs. You add that to the wild type, and the blood pressure drops to about the same level. So you can get about a 30, 40 millimeter drop of blood pressure by giving openers of these KATP channels. In the VM animals, where the KATP channels are already active, giving pinacidil doesn't cause much more lowering. This is data from SUR2AV animals, and you see essentially the same picture. Blood pressure isn't quite as low in those, and there's a little bit more lowering with pinacidil, but still essentially the same picture. And the hearts are much bigger in the VM and the AV compared to wild type. So hearts are bigger, blood pressure is lower. This means that so why is this? Well, coming back to the expression of these channel subunits, I said that 6.1 and SUR2 are in smooth muscle. Skeletal muscle and cardiac muscle are kind of unique in that the channels are not made of the canonical pairing. What we see are channels made of KR6.2, which is the other pair of genes, with SUR2, and not KR6.1. So KR6.1 is not really expressed in the heart. I'm going to come back to what that means later on. But first of all, let's look at what's going on in smooth muscle. These are isolated smooth muscle cells, and these are recordings of KATP currents which show how the gain of function that we see in these, it's confirming the gain of function in the physiological behavior of the cells. So these are under conditions where we have high K in the pipette, low K initially outside, and hold the cell at minus 70 millivolts. This is for the electrophysiologist. I'm not going to show much electrophysiology, even though that is what we do. And then we switch the external solution to 140 K, and that'll switch the EK to 0. So at minus 70, we get an inward current carried by potassium channels. And it's not very big in control, and if we add pinacidil, it goes up a lot. And then if we add glibenclamide, which is one of these sulfonylurea blockers of the channel, it goes back down again. If we look at, in this case, the V65M smooth muscle cells, there's no current in low K, but when we switch to high K, you see an enormous increase in current already. So this is KATP being spontaneously active in these conditions. And we add pinacidil, there isn't much more increase. And glibenclamide actually, and I'll come back to this point, only inhibits the pinacidil-activated current. So it doesn't seem to decrease the basal KATP under those conditions. And in the AV animals, we see essentially the same behavior. Okay, so what is going on? Well, under normal conditions, the heart is pumping normally and we get normal tissue perfusion. This is a schematic of the heart and the vasculature. The primary consequences of the CAN2 mutations are to cause increased K conductance in smooth muscle, which is going to relax it, which is going to relax the vessels, and I've showed you that they are enormously dilated. If nothing else happens, and potentially there's no primary effect in the heart that's going to increase contractility from this mechanism. So the heart is presumably not pumping enough blood if it stayed the same size to maintain tissue perfusion. So then there has to be a secondary compensation, which is leading to this cardiac hypertrophy to elevate cardiac output and maintain systemic perfusion. And when we looked at what it could be, we find that in VM animals, there is a significant increase in renin activity, which is released from the kidneys in response to low perfusion, and an increase in angiotensin II. And angiotensin II signals to the heart to increase heart size and increase contractility. We can block renin-angiotensin signaling with captopril. So if we take wild-type hearts and treat them with captopril, nothing much happens. But amazingly, after, I can't remember how long the treatment was for, maybe a week, but if we took at VM hearts that are very enlarged, give captopril, the heart size goes back down again. So we can block the effect with captopril. We can also block it with losartan. And what happens, you see here's no real effect of captopril on the wild type, but the VM animals the heart size essentially comes back to normal. Same is true for the AV het or homozygous animals or the VM animals treated with losartan. But this comes at the expense of perfusion, the blood pressure. So if we look at what's happening to blood pressure, which in the wild type it's lowered by captopril, in the VMs, which already have low blood pressure, it drops to incredibly low levels after treatment with captopril or losartan. So this is not a good therapy. Well, what it's doing is blocking the compensatory effect. And actually, because of misdiagnosis as heart failure, patients have been given losartan and captopril, and they should not. But instead, what we would ideally want to do is block the primary problem, of course, block the overactive KATP channels. And so instead of coming back from a compensated state to a decompensated state, we should actually normalize it. So we've shown that, and I don't have the data, but Connor showed with smooth muscle directed dominant negative knockdown of the channels that you could reverse everything, reverse the heart size, maintain blood pressure. But I'll show you the data that we got with glibenclamide, which is the sulfonylurea blocker. So here's just some images of a wild type heart, an AV placebo-treated heart, and a glibenclamide-treated heart, where we began treatment at 2 months of age and implanted slow-release pellets under the skin, releasing, in this case, 19 milligrams per kilogram per day, which is quite a high dose of glibenclamide. And that essentially normalized the heart size. Here's the data over multiple animals with 0, 1, or 19 dose, the dose. So the highest dose did bring the heart size essentially back to normal in these AV animals. And unlike losartan or captopril, the blood pressure didn't plummet. What happened is the blood pressure actually, at 19 milligrams per kilogram, there's a significant, small but significant increase of blood pressure, essentially back to control. So we've got decrease of the heart size, increase of the blood pressure, the vascular resistance goes up, so we're actually clamping down the vessels, and the cardiac index goes back to normal. So this is a great result, and it says, well, maybe this should be a treatment. And I haven't gone through the data in detail, but I will point out a bit more on the next slide that, of course, when we give this drug, glibenclamide is a commonly delivered drug, not so much in America anymore, but in other parts of the world, it's still given commonly to treat type 2 diabetes, because by triggering excitability of beta cells, it causes insulin secretion. And although it's a magic bullet treatment for neonatal diabetes, which is caused by gain of function of KATP in the pancreas, it's not an ideal drug for type 2 diabetes. And the question arises, if we give this drug to treat Cantu syndrome to somebody or an animal that's got an otherwise normal pancreas, what's it going to do to the pancreas? Is it going to cause blood sugar lowering? And the answer is it does in mice, but it's only very briefly. Only within the first day or two of implantation of the pellet, and then everything seems to normalize. And we've shown this in multiple other cases. At least in mice, there is some compensation for the drug, which makes the hypoglycemic effect go away. I think there's reason to believe that that might be true in people as well, and I'll come back to why. But before I get there, just to point out, we've done many studies now of different aspects of Cantu, and I don't have time to talk about them all, including skeletal muscle pathologies that are arising, which can be treated potentially by glibenclamide. We have shown that there is decreased contractility of the gut through the same problem of smooth muscle. And again, if we treat with glibenclamide, we can increase motility in the gut. Same thing in lymphatic vessels. This is the work of Mike Davis, who's at University of Missouri. He's an expert on lymphatic contractility. The lymphatic system is lined with smooth muscle, and it's the same problem. And so the reason they have edema is because they don't pump the lymph back up into the circulatory system, and so you get peripheral pooling. So what about treating people? Well, we've reported one potential success so far, which was a baby in Australia that was having very severe breathing problems and was on continuous positive airway pressure. They tried everything they could, and the clinicians were running out of ideas, and they said, well, what can we treat this baby with glibenclamide? And so they tried it, and you can see that when they before they gave the baby glibenclamide, the baby was incredibly swollen, doesn't look healthy, and you can see the clear effects of Cantu syndrome on the hair. Within about a month of treatment with glibenclamide, a lot of the swelling went down in the baby, and this is at about 9 months, I think. The hypertrichosis doesn't go away, and hyperflexibility, which is there, doesn't go away. But a lot of the baby had no obvious swelling at this point, and now the baby it's a boy of about 7 now, and apparently, although he hasn't been properly worked up by a cardiologist, I think, but they say that there is no cardiac problems. Now, we've had a couple of other babies who did not fare so well, one which could not tolerate glibenclamide, and another one that was very premature and unfortunately died. But so, and we don't think it's related to the glibenclamide, but we really don't know at this point. We've got IRB approval for a clinical trial of glibenclamide in older people at 14 years of age, and we're bringing them back at every 6 months for echocardiograms, stress tests, MRI. We don't see too much hypoglycemia in them, and if they have a little, they learn how to deal with it by carrying some sweets with them. We've had 3 individuals so far. The longest has been for 2 years, manageable hypoglycemia. They all seem to report an improved exercise tolerance. There is some hints of lowered cardiac output, but we need to do more. We need more repeat measures because echocardiography is not absolute. And there's possible improvement of lymphedema in some of them. So we're still hopeful it'll work. But how long do I have? 2 minutes? No time. Okay. Then I'll stop. I just wanted to point out the potential complications. I've already told you who did the work, and I'll stop there. Thank you.
You've alluded to the different subtypes of. Thank you. You've alluded to the different subtypes of.
You're still not on, I think. Or you're not talking into it.
Better now? So you've alluded to the different subtypes of KATP channels, and you've also alluded to the pharmacological effects of glibenclamide that basically block them all. A little bit with more sensitivity for the pancreatic ones than the other ones. And I understand why you've used glibenclamide because it's an FDA-approved compound, right?
Yes.
But there is a compound that you know about, which is PNU some number that is 6.1 specific.
PNU 37883A, which is maybe more specific to 6.1, and I don't have all the data in here to show you, but there is a clear, especially if we look at the different mutants, there is a clear difference in the sensitivity of different mutants to different drugs. And some of them are more sensitive to PNU, some are more sensitive to glibenclamide. And so actually, combination therapy is a potential route that we're trying to test. And so there's a lot of things that we're still trying to test in cells and animals.
Thank you. Any other questions? Yes, there.
Thank you. Wonderful talk. I was wondering if the effect of glibenclamide tends to plateau in other tissues in a similar way that it plateaus with the pancreas, right? At some point, the pancreas cannot excrete any more insulin, and the pancreatic cells just die. Does sort of same thing happen with other tissues?
So I don't think the pancreas plateaus. It doesn't die if you treat it with glibenclamide. Glibenclamide does not damage the pancreas. In fact, what happens is there's some sort of compensation that downregulates the insulin secretory process itself. So morphologically, the cells don't change. It's just some compensatory effect. It's possible that there could be some additional compensatory effect in this case, but I somehow don't think that's likely, because this is essentially an aberrant situation anyway. There's a gain of function, so we're bringing things back to normal in this case. And as has proven so far to be the case with neonatal diabetes, that glibenclamide therapy in neonatal diabetes after now 10 or 15 years is maintained in children who receive it and adults who are receiving it. I don't know any evidence for failure in those people who are getting it to treat overactive KTP in neonatal diabetes. That's not true in type 2 diabetes, where the defect is somewhere else. And so there, the channels are being pushed inappropriately.
Thank you very much.
Yeah, thank you.